Um, we are ready to proceed to the next session, which is a satellite session sponsored by Boston. We have the great pleasure to have with us Nico Reinsch, who is a renowned electrophysiologist from Essen. I know that he had a really hardship to reach here, missing flights and all this stuff, but he managed to be here. So we can enjoy a very nice lecture on PFA, tip and tricks. As you know, PFA is a new non-thermal energy, very popular. There is a lot of promising results, but let's see what is his opinion, and we really looking forward to hear your opinion from a sender with a very huge experience on this topic.
Yeah, thank you very much for your kind introduction. So it's a great pleasure for me to be here, and my task was to give some tips and tricks for optimal results. So I really tried to keep it practical. I don't want to focus on too many studies and outcome data. I think most of you are already familiar. We have seen many data at the AR Congress this year. So currently it's the HRS Congress. So many papers will be presented there as well. So I tried to keep it very practical and give you some insights on maybe our workflow, which is not the only workflow. But of course, it's more coming back, like you have seen in the cases before, nice 3D maps, LAT maps, voltage maps. And now with PFA, currently we slightly come back more to fluoroscopy guided procedures. And I want to try to give you some tips and tricks how to optimize your results. So these are my disclosures. I don't want to focus on details. Of course, you all know it's non-thermal, and what we aim for is irreversible electroporation. And how it works is that the threshold to tackle all the tissue in the myocardium is the threshold is much less than in surrounding tissue, and that is the way how it works. So most of you, I guess, have seen already at least a few cases, maybe live presentation as well, just as a quick reminder. And this is a so-called multi-level PVI. So we have two different positions of the catheter or configurations. This is a basket configuration, which you can see here on top. And this is a so-called flower configuration. Of course, this is what makes the catheter famous. You see it below. So we aim all veins in two different positions. This is for the basket position in a more ostial position, and this is for the flower configuration, a more antral position. And you give 4x4 applications, which means 4 in flower configuration and 4 in basket. And after 2 applications, you rotate about 33 degrees to cover circumferentially the whole aspect of the vein and to avoid any gaps. The problem we have so far is with the system, we don't have any 3D mapping. At the moment, you can include it in some mapping modalities with all those features, but was not currently made for 3D mapping, and it's more or less a fluoroscopy guided procedure. Second, we don't have really reliable EGMs, because when you see there's only one electrode, it's the third electrode on each spline, and you can see that the distance in between those splines is very large. So it is up to 2 centimeters in the largest configuration of the catheter, which means that we don't have a very high density mapping catheter at the moment. The problem also is after the first application, when you start ablation, almost all signals are gone. So you can't really rely on the EGMs you see after the first application, because you only have blunt signals. There's stunning, there's already electroporation, which means we really have to rely on our position. Third problem is we don't have a real tissue contact indicator. There's no contact force. There's no impedance mechanism. So it's only about guidance from fluoroscopy. And the problem, all of you, I think, are familiar with cryoballoon ablation. We don't have the option for any occlusion venography. And even the problem which we have with this catheter, it's not that forgiving like a balloon, which you can see here. You have a different configuration of the wire and the balloon with regard to the sheet. And even though you have a more or less suboptimal position, you can reach total occlusion of the vein. So the only thing we have, and it all comes down to optimal catheter positioning, which means what kind, and this is what I'm going to show you now in the next minute, what kind of options do we have to optimally position the catheter to achieve complete pulmonary vein isolation. And these are the tools we have. This is first CT angiography. We can use selective PV angiography. We have some indicators for catheter tissue contact, and we can use orthogonal fluoroscopical angulations, and all those different parameters I'm going to show you, and all these conclude in the 4 C's, and I will just show you later on what this means in detail. So first, this is in CT angiography. We included in the Carter system, so you nicely can see here a 3D reconstruction. And first of all, we have to make a choice, which catheter are we going to choose? We have 2 different options. This is the 31 millimeter catheter, and this is the 35 millimeter catheter you can see over here. When you look into all those data, more or less 95% of all catheters used are the 31 millimeter catheter. 35 millimeter catheter is only used in a very low number of patients, also in the large registries. And what we always do in our center, before we start the procedure, we have a look at the CT and we measure each vein. You can see here, this is a right inferior, which is quite large with a diameter of more or less 27 millimeters. You look here, the left inferior is 25. Now we look in an oblique view. And the second, and this is sometimes the problem, is that you have also quite different carina. This carina is only 3 millimeters wide, and here on the right side, which is much more common, you have a quite wide carina of more or less 2 centimeters. So we may have to make a choice. Finally, the total diameter on the left side is 35 millimeter, and when you see on the right side, it's up to 55 millimeter. So we have to have a strategy how we can cover all those areas within the atrium. And our choice is always if we have a vein larger than 27 millimeters, and if we have a total diameter from top to bottom, either on the right or on the left side, of more than 45 to 50 millimeters, then we're going to choose normally the 35 millimeter catheter. So it's not about the volume or the diameter of the atrium, it's more the measurement of the veins, each vein, the diameter of the carina, and the total distance to choose which catheter we are going to use. Sometimes the problem is you have small veins and you have a wide carina, especially on the right side. And then you have to make a choice how you're going to ablate. And in this case, we are more or less using a stepwise approach. So you can see here, first, we try to wire in superior branch, and we really focus on the roof. But what you can see here is now you completely miss the carina. So second, we rewire and we give extra applications in an inferior branch to also cover the carina part. And then when you nicely ablate the inferior vein, you see that we totally cover the carina. This is quite important because otherwise you may have a gap, and again, this may cause some sort of PV tachycardias. What's about the common os? So we often see a common os, and the common os we normally treat like 2 separated veins. We make no difference. So first we try to wire the superior branch, ablate the superior part, and you can see here if there's no carina, what often happens is that the inferior splines may jump inside the vein, but we don't care about this because if you don't have the carina, it makes no difference. You really can focus on the superior part, you can focus on the roof, and afterwards you wire the inferior vein, and then you only focus here on the floor, on the inferior part of the vein. And again, if the superior petals are prolapsing inside the vein, we don't care about, because there is no carina and we don't have to ablate the carina in this case. This was a funny case. So we did a CT before and we decided not to go for PFA in this case, because this, of course, is a quite challenging anatomy. And of course, this is very seldom. We don't see that very often. It's just to give you an idea of sometimes maybe there are patients that are not the best candidates for a more or less single shot device. So in this case, we did a 3D case and encircled this whole area. When it comes to transseptal puncture, I think this is the same like in cryo. We always try to puncture slightly more anterior. It's more or less mid-septal or in the mid of the fossa ovalis, or slightly more anterior, because I will show you this later. Especially on the right inferior vein, you have less space to maneuver and to open and to close the catheter. So this is very crucial to have enough space, and that's why we puncture slightly more anterior. We don't have eyes, so we normally don't use echo as well. So of course, it's always a bit theoretical, and after your transeptal puncture, you notice, okay, was it enough anterior or not? But if you use eyes, so in Germany it's not that common, I think in Greece as well, like in the US, but if you use TOE, you can nicely guide your transseptal puncture to be slightly more anterior. When it comes to the procedure, so we have to decide which catheter we are going to choose. We always bring the CT in an RAO and an LAO position standard to our fluoroscopy monitor, and we compare it to the fluoroscopy. So I exactly know in which branch I am when I start with a procedure. So this is an LAO view and this is an LAO view. And now comes a very important point. We make an angiography. Because when you see the CT, maybe you know in which branch you are. You know the diameter of each vein and you know the configuration. But the main goal, of course, is to bring the catheter in an optimal ostial position. And without any imaging modality, you don't know where your ostium is. So, and here you nicely can see we're in a superior branch of the left inferior, and you nicely can see the drop-off over here, and you nicely can see the drop-off over here. So now I exactly know where the ostium of my vein is and where I have to position my catheter. Second, this is not the perfect branch, because the catheter always wants to follow, it's quite difficult with this pointer, wants to follow the wire, which means you have a more or less oblique position to the ostium, which is more or less vertical of the vein. So what we always try to do is to bring it, especially on the left inferior, into the inferior branch, because then you have an horizontal position of the sheet, and then you can reach for vertical position of the catheter, and this brings you in a really nice perpendicular position to the vein. Otherwise, if it's more or less oblique, what may happen is you have enough push here on the superior part, but you may miss the inferior part of the vein. So always think about, is there an optimal branch? Is there a better branch I can wire to bring the catheter in a really optimal position? This is really crucial when using this catheter. How do we do this? Normally we use 8 to 10 milliliters of contrast. We give it over the side pod of the sheet. So the sheet is irrigated and there's a second side pod. So you can use a Lurlock, large syringe, 20 mils, and we just have to press once hard. Maybe you have a pump. It's also okay. We just use a syringe and then we nicely can see the vein. This is now the left superior. We exactly know where the ostium is. Sometimes you also can nicely see all those branches. And then you can aim for the optimal position, both in flower and both in the basket configuration at the ostium. Third point, indicators of catheter tissue contact. This is a figure we made during a course, so that's why we copied it here into the presentation. So what you can see here, this is in right inferior, and you nicely can see you have the superior branch, you have this middle branch, and you have this inferior branch. And when you're in here in the superior branch, like in the left upper part of this figure, you see that the configuration of the catheter is more or less here in the superior part. So what we decided to do is we decided the middle branch is going to be the optimal one, because then you nicely can cover both the superior part as well as the inferior part. So what you can see here is the angio. You can see all those three branches, superior, middle one, inferior one. We curved the sheet, we pulled back the wire, then we advanced the wire. So now we are in the middle one. And then we bring the catheter in the optimal position. And if you have a roadmap with your angio, you also can nicely check if you have the correct height, which means that you nicely cover the superior as well as the inferior part of the vein. And you also can check if you have good proximity to the ostium of the vein. And this is what you also nicely can see. All the pedals are back bending, which means that you're in a very good proximity to the vein. Second, always check into an oblique view, because you have to know whether you are in a good coaxiality, which means that you're not have no deviation to the posterior or anterior part. So the wire and the catheter always have to be in one line, which shows you that you're in a good position. So always, this is also very crucial, always check into in an oblique view. And this is what we're looking for when we know that we're in a good position. This is a swimming jellyfish. And if you see those pedals moving like this, like a jellyfish, then you know that you have a good and stable contact to the tissue. This is an optimal position for ablation. Sometimes you need some extra contrast. You see that it looks pretty okay, but you still see that there's a gap here on the superior part. So without an angio, you might estimate, okay, this is a good position, let's go, let's ablate. But without an angio, you're going to miss here the superior part, and maybe you have a gap at the roof, and you won't be able to isolate the vein completely. This is the right inferior now. So you see the catheter, the wire inside the right inferior. And what you can see now is, this is what you always have to take care of, is the cobra. You see lateralization of all the splines on one side. And this is always happening if you have close contact to the tissue, if your catheter has no space to properly open. And what you can see, what we do here is we open it. It looks very funny and a bit scary, but we open the catheter very slowly, and we always continue with the rotation. And this nicely helps the catheter to open properly and each spline to separate. If you continue opening the catheter with lateralization on all sides, then you may have entrapment of two of those splines, and maybe it's not possible to close the catheter correctly anymore, or to deflate it correctly. So that means sometimes you have to take the catheter out, take the splines separately manually, and then you have to bring it back into the vein. So open very slowly. There's a second trick. You can stay, especially for the right vein, you can stay also in the flower configuration, which means when you move from the right superior to the right inferior, what we do normally, we stay in the flower configurations also to avoid this maneuver, which can be very tricky, especially at the right inferior side. This is a slide from the company. You can see here again this lateralization. So there's too much curve on the sheet. All splines are separated on one side. So you have to pull back the sheet. You have to give the catheter more space. And then you can see all those splines are nicely separated. And this is what you also can see nicely in an orthogonal view here for the right inferior in LAO. Coaxiality is very important. So especially because of your transeptal puncture, the sheets always want to be pushed to the left, to the posterior wall. So you always have to try to rotate more anterior, not to miss the anterior part of the veins, because all studies show that especially on the anterior parts, you found most of the gaps. So you have to actively rotate counterclockwise on the left side to be anterior, and of course clockwise on the right side. And this you also nicely can see if you always check in an orthogonal view. So 2 views is very, very important in these cases. Oh, it's not working. So these are the 4 C's we consider to be very, very important. First, give some contrast. So if you give contrast and you have an appropriate angiography, you nicely can see each vein, you nicely can find out which branch is going to be the optimal one. And you nicely can see the ostium. Second, coaxial alignment. So spend time to manipulate the sheet to ensure there's no compromise in alignment, and you have a nice coaxiality of both the sheet and the wire. Circumferential coverage. This, of course, is the end, so that you have nicely antral lesions. And of course, there are some signs of catheter tissue contact, especially this jellyfish configuration shows you that you're in a nice position. So focus on catheter positioning for durable PVI. Take extra time. It's not a race. So everything you hear on the Congress is the speed, speed, speed. So everybody wants to do the procedure in less than 30 minutes, especially in the beginning. Take your time. It's not a race. You will end up very quickly, even if you take more time, because your patient is never going to ask you if the procedure takes you 35 or 45 minutes, but he's going to ask you why I again have atrial fibrillation. We can skip this maybe, and just maybe 2 minutes more and outlook on it, what it looks like, especially if you go beyond PVI. We have seen this nice case with a different system a few minutes ago. This is baseline and this is post-ablation, so you nicely can see all those antral lesion sets in a paroxysmal patient. But when it comes to persistent atrial fibrillation, you have a dilated atrium, you have a more diseased posterior wall, and this is what it looks after PVI. And if you see this picture, I think you're not going to be very happy with the results. So because this, of course, may be some substrate and maybe result in a critical isthmus in those patients. So when it comes to re-PVI, and of course this is about posterior wall ablation, this is still an off-label use, but it has been done in quite a lot of studies, and this is our workflow, so we don't do this. Maybe this is open for discussion as well, not in a first 2 procedures. So when we go for first 2 procedures, it's always just PVI. But sometimes when patients come back after 1 or 2 procedures and they are still in atrial fibrillation, we make a nice map and we see, okay, all those veins are isolated. What can we offer to the patient? And in those patients, we aim for an Olympic approach. Why Olympic approach? Well, because we still do this with Cartus. I think very soon we can do it with Rhythmia as well. So when we have image integration of the catheter into the Rhythmia system, by now we do it with the Cartus system, and I think it's clear why it looks a bit like an Olympic approach. So when patients come back after at least 2 procedures, still in atrial fibrillation, all veins are isolated. Then we discuss with our patients to go for posterior wall ablation, which means flower configuration, overlap of at least 30%, and anchoring lesions to the veins. And we do 4 applications on each spot, which means 2 by 2. And then we go to the next spot. And here you nicely can see both posterior wall as well as roof ablation. So this is our workflow, de novo ablation, PVI only. And by now we started in March 21. Now we end up with 100% PFA in all comers just for PVI. So there's no cryo anymore and there's no RF in single PVI. Redo 100 RF touch up to see if there are any gaps. We still see some gaps in PFA, of course, as well. And if the patient comes back after a second or more redo procedures, then it's irrespective of PV status, because it's easy, it's feasible and safe. We go for, again, complete PVI using the Farapulse catheter. And finally, we end up with roof and posterior wall ablation in those patients. Thank you very much.
Thank you, Nico. That was a really great talk, and you shared with us many tips and tricks, and we are really very, very useful for a procedure which is new and we may use in a very quick way, not paying a lot of attention to all these spots that you elucidated. Is there any question from the floor? Dr. Jace?
Congratulations, first of all. Thank you for sharing your workflow. At least in our approach, we use a nice, so this makes things really better in order to make sure that we have appropriate contact with the tissue, which, as you pointed out, is a major factor that can enhance procedural efficacy. Regarding your approach, you said that in all de novo AF ablations, you perform routinely PFA, correct?
Yeah.
What if, and we all know the caveats of using PFA in CTI ablation. What if the patient has also typical flutter in his past medical history? Do you still prefer to use PFA and taking the risk of associated complications?
Yeah. This is a very important point, I guess, because this is a catheter which was, of course, designed for PVI and not for posterior wall, mitral isthmus, superior vena cava, of course, and CTI. But you see many physicians also use this catheter for different hypotheses. You always have to be aware, if you go beyond PVI, that you may have a higher risk of coronary spasm. This is of course a big issue. So we never do CTI and mitral isthmus with this catheter. So if the patient comes to our clinic and we have to target both the veins as well as some sort of atrial flutter, we don't use this catheter. Then we go for point-by-point ablation, and not for PFA using this catheter. So we don't do, and this is off-label. If you use this catheter for CTI, then you definitely have to pre-treat patients with nitro to avoid spasm, but this is an off-label use, of course.
And I'm pretty sure that you know the data regarding it's of course retrospective of the Euphoria registry that showed that when you do posterior wall, we know it's retrospective, it's not randomized, blah, blah, but what's your opinion? What's your guess? What is your thoughts? Does it make sense to use PFA at the posterior wall in persistent AF?
This is a master question, I guess. So yes, I think but we have to select patients. So when you look also into the manifest data, there was a publication on the manifest data as well. We were part of this study and also co-authors, and there was no difference with regard to posterior wall isolation. So it was the same outcome. The problem is, if you look into this data, it was a of course, very heterogeneous group of patients. There were patients with first two procedures with posterior wall, second two, third two. So it was a mixture of patients. So I think we have to wait for the advances in the Avantgarde study, which will be hopefully presented next year. Persistent atrial fibrillation with posterior wall ablation, randomized. So to see whether there's any benefit of posterior wall ablation, not only retrospective data. I think, yes, there's going to be some benefit, but we have to select those patients. We need more data, which patients are going to benefit. With this posterior wall like this, maybe you have some patients with a more or less healthy posterior wall, even in persistent atrial fibrillation. Maybe this is a wrong population group. I don't know, to be honest. But yes, I think there's going to be some benefit, but I don't know which are the right patients at the moment.
Yeah, I will give the microphone to Dr. Stavropoulos, but before I would like to ask you, with conventional RF, we use different power, different duration of RF in a different part of the atrium. But with PFA, we give all over the place the same power, the same duration. Do you think that this is right? Do you think that this should be improved? Do you think that we should have the opportunity in the future to have the ability to adapt duration and power depending on where we are every time?
So all the studies we have so far, of course, are only validated for pulmonary veins, so nowhere else. So, and I think we don't have to, especially in the pulmonary veins, we don't have to be afraid about overdosing, because we have done so many studies now that we understand that it's really safe. We don't have to be afraid about pulmonary vein stenosis, about phrenic nerve, and so on, esophageal lesions. So I think none of us really knows the different waveforms. So at the moment, each system has a completely different waveform, and we don't know how we really can change. There have, of course, been some adaptations to the waveforms in the early studies, and with the current waveform, we have seen the best optimal results. If this is the end, if this is the final waveform, or if we have to further adapt, yes, maybe. And when it comes to the ventricle, when we come to the mitral isthmus and to different locations, maybe we have to increase or even maybe decrease the dose if it's enough. Yeah, this is still an open question.
Dr. Stavropoulos has to address a question.
Thank you for coming here to give us this excellent talk regarding the signals, as reliable as they are. It's the first time we have a multipolar catheter within the vein or in the antrum. And actually, you don't know which is which. You see a signal and you don't know which spline in which part of the vein records this signal. And then you give it a go, you deliver. Some, in a few times, and most of the times impressively it goes. But in the little percentage of deliveries when something still persists, you have to rotate the catheter in another position. And then how do you follow up this? How do you know that I have to go there? I did not abolish the signal, and then remove the catheter or come back. How do you sort this out with the signals and the...
So, to be honest, we don't really look anymore on the signals. It's always quite impressive to have the large PV signal to give the first application, and it looks more OLED gone. But after the first application, you can't really rely on the signal. So that's why we gave up to look on all those signals. What we did in many cases, especially in the beginning, we did 3D mappings to understand what we did, to see if we were in the right position, to see if we have some gaps, to see if we were too ostial or if we even were too antral. So especially in the beginning, we didn't understand that we have to rotate. So we were too close to the posterior wall, and we really created an isthmus at the posterior wall. So that's why, especially in the very beginning, there were many patients coming back with left-sided roof-dependent atrial flutter. So this is what we learned from the very beginning. But we don't check the veins after we ablate. So we don't go in there with a maybe lasso or pentaray catheter. You can go in there with an olive, the catheter in an olive position to pace, to see if you have oxide block. You can do this. But we don't see any advantage. So we think if you really focus on positioning, then you can achieve the optimal result. And yes, there's still some debate also on the congresses if 3D mapping is necessary using this catheter. There are some colleagues clearly saying, yes, we need 3D mapping in all those cases, and others say no. So I don't really believe that you have a single shot device just going for PVI. You really need a 3D mapping system, but I think you definitely need some sort of imaging. And this can, of course, different sort of imaging like angio, CT, maybe rotational angiography if you have ice. The US guys always use ice to see if you're in a nice and good contact to the wall. I think this is really crucial. So we almost never look on the signals. And the problem is, if you see some residual signals, there's no marker on your catheter which spline is where. So
That was my question.
so you don't know. You don't know where to go. So then, but that is the problem. So that's why we don't check.
Thank you.
There is another question from Dr. Levedopoulos. George?
Thank you very much for your presentation. I liked your workflow, especially because you aim to have RF at the second procedure when you have a redo paroxysmal AF procedure. What I mentioned also in my presentation is that at the end I made some comments that I think that sometimes this catheter we have some overuse, inappropriate use of this catheter to ablate extra PV locations like the posterior wall. And I like that you didn't insist much on that, because I think we create, in some cases, we create a second generation of population with atrial tachycardia in the future, and we will see the saga of this in the future. My question is actually, I started recently PFA and my radiation time is about 20 minutes. What should I aim for? What do you think is the threshold, the lowest I can go for? Where if I follow all this workflow that you presented to us, and I have this meticulous guidance with the wire, all the things that you showed to us today without 3D mapping system, because this increases the cost, how much radiation time should I aim for? What would be a nice...
So if we have a standard case, of course, not every case is standard. If we have a standard case,
Yes,
and
standard
we
case.
make an
Just
angio,
PVI.
we make separate angios, just PVI, we check in an oblique view. So total procedure time in our lab with all those features is about 35 to 40 minutes, and fluoroscopy time is more or less than 10 minutes. So we try to be less than 10. But for me, time, what you have seen is we always try to collimate. So I think time is not the most important factor. So if you collimate and you can reduce dose, I think this is, especially for you as a doctor standing there all the day, even more important than to reduce fluoroscopy time. So if it takes 2 minutes more fluoroscopy time to achieve an optimal result, and you collimate and you have even lesser dosage, I would prefer to have 2 more minutes of fluoroscopy for the best result, even with less fluoroscopy dose.
Do you think that we go for a day case procedure with PFA? Could be a day case procedure?
Yeah.
In your hospital, is a day case procedure or?
Yeah.
Oh, right. Okay.
So first do PVI, no atrial flutter, nothing else, just PVI is now 100%. So we never did really cryo cases before, so we were 100% RF. And in the very first beginning, this was according to the IFU, we stick to the paroxysmal patients. And after 1 year, we said, okay, we do the same approach in paroxysmal as well as persistent. So we completely switched to PFA. Yeah, and we see almost no tamponates anymore. I think it's very safe. We can increase the daily number of procedures, especially when you think about same-day discharge, which is coming up now in Germany as well. So there's more and more discussion. So I think in 1 or 2 years we have to deal with it as well. So, and especially when you think about all these new things popping up, I think PFA really can be a game changer. Yeah.
And according to your opinion, how long is the blanking period after PFA? We use 3 months for other procedures, though we all know that if you have recurrence during this period, in reality, it's very likely that you're going to have AF again. But in any case, we use this blanking period.
Yes.
Do you think that this is different with
Yes,
the PFA?
I think so. There have already been published some data also as abstract on the congresses. So we definitely have to reduce the blanking period. I think more or less 4 weeks is be okay, because when you look into those data, when people having recurrences even in an early phase, the number of late recurrences is much higher. So even maybe 4 weeks is still too long.
Stelios?
As you know, 1 month ago, the consensus on air population was released, and the new duration of the blanking period has been shortened from 3 months to 8 weeks. And the reason why we did not proceed to any
Further shortening was that if you decrease further the duration of the blanking period, you increase the false positive rates. So the concept is to protect patients from an unnecessary redo procedure.
Yeah.
So the new duration of the blanking period is 8 weeks. And this is official, and there is a strong suggestion to be implemented in all future AF ablation trials.
Yes, of course, we have to think about if we completely going to switch to PFA, maybe in the future, maybe, I don't know. I think from a practical standpoint, you're absolutely right. And of course, this is very carefully written in the guidelines to avoid unnecessary procedures, to bring all the patients back after just one short recurrence back to the lab. So I think 8 weeks is a very practical reason. From a research standpoint, just to think about the methodology of and the sort of kind of ablation, I think it can be even reduced.
And to remind that Dr. Zeiss is the first author in this new
And I fully agree. I fully agree. So
Yeah.
absolutely.
And it's my question. Do you think that with PFA may change the strategy of manipulating anticoagulant drugs? Let's say that we have someone with SATVA score 0, and we may consider to stop anticoagulants after ablation. With conventional ablation, we use as a window of 3 months, 2 or 3 months.
8 weeks.
Do you
8
do you
weeks.
think that with PFA this may change this different energy? Do you think that this may affect this decision in terms of some people, they say that with PFA we may create less edema.
We still see some edema, so it's not correct that we don't see any edema. So we still see some edema. Of course, this is different types of cell death with PFA, so this may reduce in lower thromboembolic risk in an early phase. But to be honest, I don't have any data supporting this at the moment. So I think to give a recommendation to stop anticoagulation earlier because of PFA procedures, I think we don't have any data for that supporting this at the moment. So even in a patient with SATVA score of 0, we still continue with anticoagulation for at least 8 weeks. And after 8 weeks, we continue depending on SATVA score.
I think that we reached at the end of this session, which was really very, very useful. Thank you very much for coming and really giving this superb lecture and all these tips and tricks on PFA. Thank you very much.